Welcome to Doctoring the Truth, the podcast where we pull back the curtain on healthcare gone wrong. I'm your host, Jenna Tennell, and with me is my delightful co-host, Amanda House. We're two doctors of audiology here to bring you inside real-life cases where once trusted healthcare providers veered off the ethical path into criminal territory.
Hi. Hello.
Heyo. Yeah. No, I don't have that Arabic twang down quite like I'd like to. I'm going to have to work on that. Sorry, Alley Cats.
I liked it. I just had to chuckle before that was even squawking. I couldn't hear the intro music, but I could see that you were jamming with your headphones on. So I was like, well, it must be playing. Silence on my end.
Listen, everyone, I got a software, what everyone dreads. Whenever you get used to something, especially as older folks, you finally figure a program out, and guess what? They update it. Wah, wah, wah. So I don't know why you can't hear it, but it's there. I see the little waveforms and I can hear it. So
no, that's fine. I appreciate it. It's
baby.
Like what are those parties people go to when everyone's wearing headphones, but everyone's dancing?
Deaf parties. Yeah.
Fine. Okay.
Don't
No.
deaf parties? Yeah.
I don't.
Is that not
no,
PC?
I would
Probably
know
not.
that. No. Is it?
You know what? Along with the wrinkled fingers that we never learned about, you're going to put that on your TD
list. Yeah. Thanks for the reminder. I got to look that up. Thanks for the reminder.
Yeah. I think it's called silent disco. Silent disco.
Yeah, that sounds right.
Yeah.
I was going to say, I've never heard it called a deaf party, and I feel like I should know that if that's what it's called. I'm like, I'm going to phone a friend.
Yeah. So, yeah, let's learn about that, because I think it sounds really cool. Everyone's dancing to their own tune. I mean, that's what they say. What is the saying about you're dancing to your own drummer, or the rhythm of your own drum?
You beat to your own drum. To the beat of your own drum?
Something like that.
I honestly had it on the tip of my tongue, but then I started thinking about silent dance parties, and I was like, she on.
I kind of want to go to one.
To the beat of your own drum. That's it.
He moves to the beat of his own drum or something like that. It's like an expression like, that dude's at a silent dance party. He's doing his own thing. And we aren't hating it. We aren't hating it.
He vibing.
Yep. Oh, what's new in the zoo? I mean, speaking of zoo, you're back at school. What's new?
Yeah. A few of my schools have started. Oh, it's so good to see those little cutie patooties. Oh, I miss them so much. And some of them I have not seen in literally a year, because some of them, I don't see them all the time. So, and then I was gone for like a hot minute. So yeah, and I had 5 new kids added to my caseload last year while I was on maternity leave. So I just got to meet one of those cutie patooties today, and they're super sweet. Oh, so cute. Yeah, it's going really good. I have obviously 5 awesome DHH teachers that I work with, but one of them and I have really kicked off this school year, and we're hitting the ground running. And the other ones, I don't think all their schools have really started yet. So we're off to a banging start in one area, and yeah, I think it's going really good.
It's nice to have a rollout, like a planned, like instead of like it all the stuff hits the proverbial fan at once. And we're gonna roll it out and delay the chaos a little bit. That's nice.
Yeah, it's real nice. Yeah. How's life up in the Northwoods? Well, no, I have to say one thing quick.
Yeah.
I walked into my garage the other day and it smelled like ladybugs. And I didn't know if we just talked about ladybugs so much last year, but like I thought of you. I was like, oh, Jenna, I wonder how she is.
Yeah. They've been conspicuously absent. I don't know if they're plotting against me, like they're rallying the troops and like gonna just
for sure
come for. Yeah. So I'm enjoying the respite, but it's kind of like,
or they remember the corgi you brought.
Maybe I just need to bring her up more often so she can eat them. Gross.
They were like, there's a dog that eats us there. Let's not go back.
Let's hope it's that and not, a plot to take over the house any minute. So I'm enjoying that. We were talking about delaying the chaos, and I was like, I've learned this new phrase, and I've brought it up to you a couple times, and you haven't reacted. So as someone with ADHD who has a really hard time, I'm talking about me. I don't know about you. Have a really hard time with time management or like knowing or planning how long something will take. So when we say we're going to start recording at a certain time, I'm just pulling it out of my ear. Like, honestly, I have no idea. So I heard someone say on a podcast that they had a soft start. And I was like, that is so much more businesslike than, 6:30-ish. So I've started telling you, okay, can we have a soft, can we start at a soft 6:30 or soft?
Yeah, you did start doing that, actually. You're like, I'm aiming for a soft 6:30. I like it.
It just makes me sound cool and in control, even though we all know probably, if those of you who know me, I'm not, but we're getting there.
Very sophisticated.
Thank you. We should probably get into it, do you think? Oh.
I would say so.
Yeah, well, the correction section. The correction section.
The correction section is that Amanda didn't do her homework.
And
not intentionally, she forgot.
Yeah, I should have reminded you.
And now we're in third person. Ew.
I talked about how I was going to talk about all this stuff today, like postpartum psychosis and some examples, ending up with, an update on the Lindsay Clancy case. Oh boy, what's that? Another example of an ADHD overestimation of time or underestimation in this case. So guess what, guys? I really was planning for a two-parter after I wrote this up. And then when Amanda spotted my next episode, she was like 34 pages.
I'm like, no. I had some more colorful language, but I'm trying to keep it PG on the pod. But it was a colorful, resounding, absolutely not. This is a 3-parter.
It was a hard stop. It was a boundary. Yeah, we got ourselves a 3-parter, folks. Welcome to my Lucy Leppy rabbit holes. It's similar to that because the more I wanted to know about this, the more questions it raised and the more fascinated I became and the longer it got. And so I hope that listeners feel the same way. If not, well, go look at our backlog. Maybe not Lucy Leppy then.
Yeah. No, I'm so excited for all 3. Obviously, this is a big topic right now with the Lindsay Clancy case ongoing. And I think it's just subject matter that people don't talk about enough. It's important and we should be talking about it. So A, for the importance, spread awareness, and B, I'm ready to dive in. Like, I'm excited to see what you put together.
All right. Well, thank you. But first, in order to put all this together, your girl needed coffee. And there's none better than strong coffee, especially from Strong Coffee Company, because they offer premium instant blends that combine convenience with health benefits. Their standout black fair trade instant coffee delivers a smooth, robust flavor while adding 15 grams of protein. I mean, 15, we talked about this before. We had an argument about yogurt, but that's more than yogurt, right? That's more than a cup of yogurt. 5 grams of MCTs and 250 milligrams of adaptogens like ashwagandha and theanine. And this formula is really going to give you lasting energy, sharper focus, calm without jitters, and supports your sleep and your mental clarity, which is ideal for all of us. It's ideal for new moms, busy moms, working moms, any moms, dads, teenagers.
Everybody.
In fact, maybe that would get my teenager out of bed on the weekend. If,
No.
if she had a better support, no, probably not. I'm dreaming now. I mean, they're not magic. They're just great. And they're committed to quality and eco-friendly practices. And they deliver great taste, quick convenience, and a nutritious boost, all in one. So use our code STAYSUSPICIOUS at strongcoffeecompany.com for a whopping 20% off your order.
Yeah.
Today. Okay, there's no nice way to segue into this, but this episode is going to discuss postpartum psychosis. And this will include discussions of the deaths of children, suicide attempts, severe mental illness, psychosis, and criminal trials. I'm going to avoid unnecessary graphic detail, but some of the facts are so disturbing, but they're essential to understanding the medical and legal issues. So if you need that warning, consider yourself warned. And like I said, maybe another episode would be more for you. But I do want to say, if you or someone close to you has recently given birth and is experiencing hallucinations, delusions, confusion, agitation, I mean, we're talking severe confusion and agitation, suicidal thoughts, frightening beliefs involving a baby, or an inability to sleep for days, treat that as an emergency. Don't leave that person alone with the infant. In the United States, call 911 or 988 or go to the nearest emergency department. If you live somewhere else outside the United States, please contact your local emergency service. And one more point before we start, postpartum psychosis is rare. Violence is not its defining feature. Most people with postpartum psychiatric illness never harm anyone. The cases in this episode represent catastrophic exceptions. We're examining them because understanding those exceptions may help us recognize and treat the emergency before it reaches a courtroom. So, at the end of a criminal trial, a jury may be asked a question that sounds deceptively simple. Did the defendant understand that what she was doing was wrong? Medicine has to ask an earlier question. Was there a moment, days, weeks, perhaps months before the crime, when someone could see that this mother was losing her grip on reality? And if there was, did anyone understand what they were seeing? Postpartum psychosis sits at an uncomfortable border. On one side are obstetrics, so childbirth, hormones, sleep loss, pain, bleeding, lactation, and the physical shock of becoming responsible for a newborn. On the other is psychiatry, mania, depression, delusions, hallucinations, and a mind that can no longer reliably distinguish an imagined threat from a real one. And on the third side yet is the law, which doesn't ask whether a defendant was sick in a general sense. It asks whether the illness met a particular legal test at a particular moment. And so those three systems all speak different languages. A psychiatrist, if you're talking to them, they might talk about psychosis. A prosecutor might say, well, there's planning involved. A defense attorney might say, well, but there was delusion. A juror is going to hear all three of these things and have to choose one for a verdict. In 2001, that collision became impossible for the United States to ignore when a Texas mother named Andrea Yates drowned her 5 children. She had already attempted suicide. She had already been hospitalized. She had already been treated for severe postpartum psychiatric illness, and there had been many, many warnings. And yet, a jury convicted her of capital murder. 4 years later, an appellate court overturned that conviction, and in 2006, a second jury found her not guilty by reason of insanity. The facts had not changed. The children were still dead. Andrea Yates had still caused their deaths, but the legal interpretation of her mind had changed completely. So today on Doctoring the Truth, we're going to look at postpartum psychosis through the cases that forced courts to decide what medicine could and could not explain. We're going to examine the evidence supporting psychiatric incapacity, and we're going to examine the prosecution's counterargument that mental illness does not automatically erase intent, awareness, or responsibility. And we will ask the question that arrives too late in every single one of these cases. Where was the last possible point of intervention? So let's start by talking about what postpartum psychosis is. because the phrase can be misleading. It sounds like a permanent psychotic disorder that happens to occur after birth. But the modern literature increasingly describes something more specific. It's an acute, childbirth-triggered illness that's closely connected to the bipolar spectrum. It is rare. It's generally estimated at about 1 to 2 cases per 1,000 deliveries. But when it appears quickly. The classic onset is within the first 2 weeks after delivery, especially between postpartum days 3 and 10. A person may begin with severe insomnia, unusual energy, irritability, anxiety, racing thoughts, or abrupt mood changes. Within hours or days, that can progress to mania, profound depression, confusion, hallucinations, delusions, disorganized behavior, or catatonia. The symptoms may fluctuate. Some can sound composed during a short conversation and yet be profoundly ill later that night. She may conceal symptoms because she's frightened, ashamed, or convinced that the people around her are part of a threat. A family may see anxiety and miss the emerging mania. A mother may describe an intrusive thought, while different listeners understand that phrase in radically different ways. There's another disorder called postpartum obsessive compulsive disorder, which we're going to talk a little bit more about in detail in our chart note. But this disorder can produce disturbing, unwanted thoughts or images of harm as well. But the difference is the person is typically horrified by these thoughts. She recognizes these thoughts as inconsistent with what she wishes. So then she will take steps to avoid knives, bathtubs, stairs, or just being alone with the baby because she's terrified that these intrusive thoughts mean something about her character, even though she doesn't want to act on it. But psychosis is different. A delusion isn't merely a frightening possibility. It's experienced as reality. So a mother might believe that the baby's possessed, that the world is ending, that strangers intend to abduct the child, or that death is the only way to protect the infant from a fate worse than death. So within this delusional system, an act that looks incomprehensible from the outside can feel morally necessary from the inside. But, of course, that distinction is not always neat because insight exists on a spectrum. Systems change. A person can be partially aware that others will condemn an act while still believing a delusion makes it necessary. And so that's the reason the medical diagnosis and the legal insanity test are not interchangeable. The strongest known risk factors for postpartum psychosis are having had a previous episode of postpartum psychosis and bipolar disorder, particularly bipolar 1 disorder. A close family history of bipolar illness or postpartum psychosis also raises a person's risk. The first childbirth appears to carry the greater risk than later childbirths at a population level. And severe sleep deprivation may act as a trigger, especially in people whose previous mania was precipitated by lack of sleep. What does not exist is a simple blood test, a brain scan, or a screening questionnaire that can predict postpartum psychosis with certainty. Diagnosis depends on clinical examination, the timeline, records, and collateral information from people who've watched the patient change. Clinicians also have to exclude medical causes, of course. So medical causes of psychosis or delirium could mean infection, thyroid disease, eclampsia, electrolytic disturbance, medication effects, substance use, autoimmune encephalitis, or complications of hemorrhage. This is especially important because the phrase postpartum is just talking about timing. It means after the birth. It doesn't prove the causation of the issue. Once postpartum psychosis is suspected, the literature is unusually consistent about urgency. This is a psychiatric emergency. The mother and infant generally should not be left alone together until a specialist has assessed them and the risk. Inpatient treatment is commonly required, ideally in a mother and baby psychiatric unit where the relationship can be supported under supervision. Treatment evidence is limited by the rarity and the emergency nature of the condition. Randomized trials are scarce, and still the best prospective cohort evidence supports a stepwise combination of sleep restoration, a benzodiazepine when appropriate, an antipsychotic, and lithium. In a specialized Dutch treatment program, more than 98% of participants reached clinical remission by the combination stage, and approximately 80% maintained remission at 9 months out with lithium maintenance. Electroconvulsive therapy can be life-saving when there's catatonia, so somebody is non-responsive, or if they have severe psychotic depression, extreme suicide risk, or the need for a rapid response. I mean, ECT or electroconvulsive therapy brings up like medieval thoughts of like shocking the heck and torturing patients. But honestly, modern ECT is performed under anesthesia, and it's one of the most effective treatments for certain mood disorders. We're just resetting the brain's pattern with these electrical shocks. The short-term prognosis with treatment is often good. Long-term prognosis is more complicated. In one 4-year prospective study of 106 women with first onset postpartum psychosis, about 2/3 had no episode outside the postpartum period. About 1/3 later experienced mania, depression, anxiety, or psychosis outside of that window. Over longer follow-up, recurrence estimates rise. When illness does recur, it's far more likely to follow a bipolar pattern than it is to become schizophrenia. So, we have an illness that's rare, sudden, severe, recognizable in retrospect, and often highly treatable. And that last phrase, recognizable in retrospect, is where this story is so painful. Let's go back to talking about Andrea Yates. Andrea Pia Kennedy was born in Houston in 1964. Those who knew her before the illness described an intelligent, high-achieving, private young woman. She became a nurse and later married Russell, who is known as Rusty Yates. The couple embraced a highly traditional family structure. Andrea stayed home. Rusty worked. They had children in relatively rapid succession. Their religious life also became entwined with the teachings of a traveling preacher whose messages emphasized sin, maternal duty, and the supposedly corrupting influence of women. Boo. Sorry, I couldn't help that. Corrupting influence of women. Anyway.
Silly women.
It's important to be precise here because I'm not saying religious belief is not mental illness. I'm not saying it is. And strict and unconventional belief is not by itself psychosis. But the clinical issue is what happens when a person's illness transforms their ideas about sin, motherhood, and damnation into fixed delusional commands. So it's just like kind of like having this environment or background of, what they're committed to and what their values are still there, but they become twisted and delusional. After the birth of her fourth child, Luke, in 1999, Andrea's mental health deteriorated dramatically. She attempted suicide by taking pills, and she was hospitalized. Soon after discharge, she held a knife to her neck and asked to die. So she was hospitalized again. Psychiatrist Dr. Eileen Starbranch treated her and warned the family about the seriousness of another pregnancy. Contemporary accounts and later testimony describe a clear concern. Another child could precipitate another severe psychiatric episode. Andrea improved with treatment, including the antipsychotic medication haloperidol, but improvement created its own trap. When a patient becomes less visibly ill, then relatives believe the danger's past. Medication might be reduced or stopped because of side effects, and the family may attempt to resume normal life. The patient herself may not understand that the recovery depends on continuing treatment. I mean, we see this all the time with antidepressants and especially severe mood disorders and schizophrenia when they stop taking their meds because they think they're feeling better or they are feeling better.
Yeah.
Well, I don't need that anymore, and then they go off the rails.
I'm better.
So,
yeah. And then we have to wait so long before they do their job again. That's a bad cycle.
Mm-hmm. So Andrea became pregnant again. In November 2000, she delivered Mary, the couple's fifth child. For a time, the family reported stability, but then Andrea's father died in March of 2001 and her condition worsened. She stopped functioning normally. She became withdrawn. She scratched bald spots into her scalp. She read the Bible intensely. She struggled to feed Mary. She reportedly stopped sleeping adequately and became increasingly preoccupied with being a bad mother. In late March, she was hospitalized, and in April, she was hospitalized again after another suicide attempt. So Dr. Mohammed Saeed treated her and prescribed medication, including haloperidol. And the family were warned, do not leave her alone. So this is the first point where the medical and legal narratives start to diverge. From a clinical perspective, previous postpartum deterioration, 2 suicide, I thought I read 3, maybe 3 suicide attempts, repeated hospitalization, psychotic symptoms, severe functional decline, and a recent delivery all form a high-risk pattern. The question becomes whether the discharge plan matched that risk and whether the people expected to carry out the plan fully understood it. Then you got to look at the flip side. Clinicians don't control a patient's home. I mean, they make decisions based on the presentation in front of them and the legal threshold for involuntary treatment, the information provided, and the resources they have available to them. A hospital can't confine someone indefinitely just because they're worried that there could be a catastrophe in the future. Families are also allowed to make choices clinicians consider unwise. I mean, you're allowed to defer treatment or refuse treatment. Dr. Saeed later tapered and discontinued haloperidol. The reasons and consequences became a major focus of later scrutiny. Mm-hmm. So we should resist the temptation to reduce the entire case to one med decision because antipsychotics have significant adverse effects. A psychiatrist might reduce them when symptoms appear improved. Records and testimony must be evaluated in the context of what the clinician knew at that moment. So we're not blaming it all on this med discontinuation. But the timing is difficult to swallow because in the weeks before June 20th, Andrea continued to deteriorate. Rusty's mother, Dora Yates, helped supervise Andrea and the children. Dora later recalled behavior that suggested that Andrea wasn't thinking normally. She appeared nearly catatonic at times and spoke very little. She watched the children eat while not eating herself. She filled a bathtub to an unusual depth and then offered an explanation about soaking clothes. That filled bathtub would later appear ominous, but warning signs rarely arrive with labels or signs. I mean, a relative sees odd behavior without knowing what it predicts. A clinician hears about insomnia without observing the delusion. A spouse sees a partner who was discharged from a hospital and assumes, well, they were discharged, so they're safe. Rusty reportedly began leaving Andrea alone for brief periods, believing independence would help her recover. On the morning of June 20th, 2001, he left for work. His mother was expected to arrive roughly an hour later, and during that hour, Andrea drowned all 5 children in the family bathtub. Noah, John, Paul, Luke, and 6-month-old Mary. I'm not going to narrate any details beyond what's necessary, but the essential fact is that this wasn't an impulsive moment. It was a sequence. Her oldest child attempted to get away, but Andrea continued. When she was done, she called the police, and then she called Rusty and told him to come home. Those actions, waiting until she was alone, carrying out a sequence, calling police, would become the foundation of competing interpretations of what happened. Was this evidence of a purposeful murder by someone who understood what she was doing? Or was it organized behavior in service of a psychotic belief? We're talking about the same facts, but there's 2 different stories you can tell from this. There's a common misconception that a psychotic person must look confused every second. I mean, in reality, people can plan within the delusion. They can plan something out. If someone sincerely believes a building is on fire, she may methodically break a window, pull an alarm, and carry children outside. I mean, that sequence is organized, but the premise is false. So the defense maintained that Andrea believed that she had irreparably damaged her children, and that killing them while they were still innocent would save them from eternal damnation. Within that belief system, she wasn't acting out of hatred. She believed that she was preventing a worse outcome. Forensic psychiatrist Dr. Philip Resnick interviewed her and concluded that she didn't know that the act was wrong because her psychosis defined it as the morally correct way to save the children. The prosecution faced a different legal question. Texas followed a version of what's referred to as the McNaughton insanity standard. The McNaughton insanity standard is a legal test used to decide whether severe mental illness prevented a defendant from being criminally responsible. Under the traditional McNaughton rule, a defendant must establish that at the time of the crime, a disease of the mind caused such a defect of reason that the person either did not understand the nature and quality of the act or understood what they were doing but didn't know it was wrong. So here we are with the word wrong, which is deceptively complicated because what does wrong mean? Does it mean that it's legally prohibited or morally wrong according to society or morally wrong according to the defendant's delusion? So a person may understand that police will arrest her, but still believe that God requires the act. Different jurisdictions and courts have interpreted this tension differently. Prosecutors emphasized evidence that Andrea understood the consequences. She waited until Rusty left. She knew her mother-in-law was coming. She called 911 and she summoned her husband home. She had made statements indicating that she expected punishment. To the state, these were signs that she knew society considered the acts wrong and that she retained the capacity for purposeful conduct. The defense answered that awareness of arrest is not the same as an ability to appreciate moral wrongfulness. A martyr may expect punishment while believing an act is commanded and right. A delusional person can know what police will do without sharing reality with the police. And so this is the point where, as a podcast, we can't cheat. I mean, it would be easy just to tell one side. If we tell only the defense story, every sign of planning becomes proof of how elaborate the delusion was. And then that interpretation is hard to disprove. And if we tell only the prosecution story, every organized action becomes proof of sanity, even though psychiatry never required disorganization for psychosis in the first place. The honest conclusion is narrower. Planning alone doesn't rule out psychosis, and psychosis alone doesn't establish legal insanity. And as a Libra, I'm riding that middle ground. Just saying. That's why I find these cases so fascinating, because you can see both sides so clearly, I would be a terrible juror. I don't know what I would have done here. Anyway, during that trial, the prosecution psychiatrist, Dr. Park Yates, testified that Andrea watched an episode of the television series Law and Order, and that she watched an episode involving a mother who drowned her children and obtained an insanity acquittal. So here we are with a very, very strong implication that Andrea probably watched the program and then therefore made her plan. But the major problem was that there was no such episode. So I don't know why he would have made that up. But I mean, this case is difficult enough without throwing Herring in there. But the prosecutor referenced the claim in their closing argument. So that's what the jury heard. And the Texas Court of Appeals later concluded that it was because of this false testimony that the case was retried, because this could have affected the jury and reversed her conviction in 2005. They weren't saying she was innocent. It was just that, the trial was compromised by this false expert testimony. So then she was retried in 2006, and the jury heard the insanity evidence again. And after approximately 13 hours of deliberation, jurors found Andrea not guilty by reason of insanity. She was committed to a secure psychiatric facility and was not released. And that outcome is often misunderstood, because an insanity acquittal doesn't mean that nothing happens. It just means the defendant is not punished as a criminal because the required culpable mental state was absent under the law. She may remain confined in a psychiatric institution for years or decades or life. It's subject to periodic review and treatment. Andrea Yates has remained in state psychiatric care, and reports indicate she's repeatedly declined opportunities to seek release. She's happy in there. And I can't remember what the name of the documentary I watched years ago when this was covered, but I mean, she's happy. She's doing crafts. She's, made a name for herself as a person to go to, kind of like a quiet, reserved mother figure. And she wants to be there. So the second verdict did not erase the fact that Noah, John, Paul, Luke, and Mary died. It didn't answer every question about the family or the healthcare system. It answered one legal question. At the time of the murders, did severe mental illness prevent Andrea from knowing that what she was doing was wrong? And that jury said yes. But now it's time to break for a journal. Welcome to the Chart Note segment where we learn about what's happening in medicine and healthcare. So, I just can't let it go. I wanted to know more. So guess what? This is also about the topic at hand. So in discussions of maternal mental health, 4 terms are often treated like they describe different degrees of the same condition: postpartum depression, postpartum OCD, bipolar disorder, and postpartum psychosis. But they can overlap and one can be mistaken for another. A patient can experience more than one, but they're not interchangeable like we treat them. The differences can determine whether somebody needs a routine appointment, urgent psychiatric care, or immediate hospitalization. So let's get started with postpartum depression. Postpartum depression is a depressive illness occurring after childbirth. It falls under the broader term perinatal depression, which will include depression during pregnancy as well as after delivery. It's more severe and more persistent than baby blues. You've probably heard people say the baby blues. The baby blues are very common. In the first several days after you give birth, you get the hormonal changes, physical recovery, sleep disruption, demands of caring for a newborn. And all of these things can produce, understandably, tearfulness, irritability, anxiety, or emotional sensitivity. So these are symptoms that are usually mild and resolve within about 2 weeks. Postpartum depression lasts longer or can cause substantially greater impairment. A person might experience persistent sadness, hopelessness, guilt, irritability, loss of pleasure, difficulty concentrating, changes in appetite, overwhelming fatigue, or an inability to sleep even when the baby's asleep. She may feel disconnected from the baby or convinced that she's an inadequate mother. Postpartum depression can involve thoughts of death, suicide, or harming oneself, and those symptoms require immediate assessment. But in uncomplicated postpartum depression, the person ordinarily remains connected to reality. She might believe she's a terrible mother, but that belief grows out of guilt and depression. It's not a fixed delusion necessarily. She generally knows who and where she is. She's not hearing voices. She's not receiving supernatural commands or experiencing profound confusion. So treatment for this includes psychotherapy, medication, practical support, or a combination of all above. Postpartum depression is serious, but it's treatable. Postpartum OCD, or postpartum obsessive compulsive disorder, can be very frightening because it may involve intrusive thoughts or mental images of harm coming to the baby. But the critical word is intrusive. An intrusive thought is one that arrives unwanted. It's not consistent with a person's values and intentions. The mother does not want the thought, does not believe it's a good idea, and does not experience it as a command that she should obey. She's usually horrified that her mind produced it. For example, a mother may suddenly imagine dropping the baby down the stairs. She may have an unwanted image involving a kitchen knife or bathwater. The image can be vivid enough that she's terrified to carry the baby near the stairs, enter the kitchen, or give the baby a bath. And that avoidance can become part of an obsessive-compulsive cycle. So the thought causes intense anxiety. So the person then checks, avoids, seeks reassurance, or performs rituals to neutralize the danger. The temporary relief reinforces the cycle, making the obsession more powerful the next time it appears. This is so different from wanting to harm a baby, because in postpartum OCD, the insight is preserved. The person recognizes that the thought came from their mind and knows that it's irrational and excessive, and then takes steps to prevent anything from happening. So the thought is ego-dystonic, meaning it conflicts with who she believes herself to be. Unfortunately, fear of being judged can prevent mothers from disclosing these symptoms because, understandably, they worry that admitting an intrusive thought will cause someone to take the baby away. So clinicians, therefore, need to ask careful follow-up questions. Does the thought feel unwanted? Does it cause fear or disgust? Does the patient believe it's true? Does she feel commanded to act? Is she avoiding the baby because she's afraid of causing harm, or does she believe the harm is necessary? Because those are 2 different things. Postpartum OCD is commonly treated with cognitive behavioral therapy, particularly exposure and response prevention. Medication may also be appropriate in these cases. So having an unwanted, intrusive thought does not by itself mean that a mother is psychotic or likely to hurt her child. Bipolar disorder. This is a mood disorder characterized by episodes of depression, mania, or hypomania. Mania is more than feeling energetic or having a good day or drinking an energy drink. It can involve an abnormally elevated or intensely irritable mood, racing thoughts, rapid speech, inflated confidence, impulsive decisions, agitation, and a markedly reduced need for sleep. That last phrase matters, reduced need for sleep. A new parent might be exhausted and likely exhausted because the baby repeatedly wakes her. Someone developing mania can sleep for a few hours or not at all and feel energized still and driven, restless, and they seem incapable of slowing down. Severe mania can include delusions, hallucinations, paranoia, or profoundly impaired judgment. And bipolar depression can also become psychotic. Childbirth is a particularly high-risk period for people with bipolar disorder. In some patients, the first recognizable episode of bipolar illness actually occurs after delivery. So that means a postpartum patient may initially appear to have ordinary depression when the fuller picture includes previous periods of decreased need for sleep, unusual energy, impulsivity, or mood elevation. It's an important distinction because treatment for bipolar depression isn't the same as treatment for unipolar postpartum depression. Antidepressants can be appropriate in selected bipolar patients, but antidepressant treatment without adequate recognition of bipolarity might actually worsen their mood stability or precipitate mania in vulnerable individuals. Treatment often involves mood-stabilizing medication, certain antipsychotics, psychotherapy, sleep protection, and close psychiatric follow-up. Medication decisions during pregnancy and breastfeeding require individualized risk-benefit discussions with the provider. Abruptly stopping an effective medication can also create substantial risk. So, bipolar disorder is not synonymous with postpartum psychosis, but it's one of postpartum psychosis' strongest risk factors. So again, a review of postpartum psychosis is that it's an acute psychiatric emergency that begins in the first few days or weeks following childbirth. Despite its name, it is increasingly understood as a childbirth-triggered affective illness closely associated with bipolar spectrum rather than just a postpartum form of schizophrenia. The onset can be abrupt. Early signs include severe insomnia, agitation, rapidly shifting mood, unusual energy, irritability, anxiety, or a sense that something's profoundly wrong. Symptoms may then progress to delusions, hallucinations, paranoia, mania, severe depression, disorganized behavior, or confusion. The person may become disoriented or appear almost delirious. Her mental state can fluctuate significantly over the course of a single day. And the defining difference is impaired ability to tell what's real. Unlike a person with postpartum OCD, someone experiencing psychosis may not recognize a frightening belief as irrational or unwanted. She may believe it's objectively true. So a mother with OCD might think, what if I lose control and hurt my baby? That thought terrifies me, so I need to stay away from anything dangerous. A mother with psychosis might believe, my baby's possessed and I have chosen to save her. Or someone's coming to take the baby, I must act before they arrive. Or a voice is telling me that death is the only way to protect my child. That doesn't mean every patient with postpartum psychosis has these kinds of thoughts. And it doesn't mean that most will become violent. Catastrophic violence remains rare, but when delusions, hallucinations, confusion, suicidal thinking, or infant-related commands are present, the risk is unpredictable and can change in a heartbeat. The mother and baby should not be left alone together. All help is being arranged. Postpartum psychosis generally requires emergency psychiatric assessment and hospitalization, and treatment, as we talked about, involves an antipsychotic, restoration of sleep, and frequently lithium, along with the electroconvulsive therapy. And with prompt care, recovery rates are high. Knowing the difference between these illnesses can mean the difference between an illness that frightens a patient and an illness that prevents her from recognizing the danger at all. So, back to our episode. Where could intervention have occurred? This is a huge thought on most people when they hear this, like, where would we have known? Where should intervention have started? So, looking back, we can identify many possible points of intervention where it would have, been potentially helpful in preventing this, but hindsight makes patterns look cleaner than they were. The first was reproductive planning. Andrea's previous postpartum episode had been severe. A psychiatrist reportedly warned that another pregnancy could be dangerous, and yet medical advice is not a command. Clinicians could counsel, but the couple still controlled their reproductive decisions. The second was medication continuity. Andrea improved on an antipsychotic and then later deteriorated after treatment changes. So that temporal relationship deserves scrutiny, but it doesn't by itself prove negligent prescribing on the part of the provider. The responsible question is whether the taper was supported by the examination of the patient, records, known relapse history, reports from the family, and a safe monitoring plan. The third was discharge planning. When a person's recently attempted suicide and experienced psychosis, do not leave her alone, quote unquote, is not a casual recommendation. We need to be more specific, like alone for how long? Alone with whom? What symptoms require calling the psychiatrist? What about overnight when I'm asleep? Who ensures that she's taking her medication? Who's going to protect her sleep? What happens if she refuses care? And the fourth was collateral information. So patients with psychosis may minimize or conceal their symptoms. So you can't have a 10-minute appointment with them and substitute that for information from someone who's actually with the patient all the time. Modern perinatal psychiatry emphasizes involving partners and family obviously with consent and creating a written plan before the delivery for anyone with prior postpartum psychosis or bipolar disorder. And the fifth was insight into risk. Families might hear the word depression and imagine sadness, because if you haven't had depression, that's what you probably think it is. They may not understand that psychotic depression can produce false beliefs, commands, or distorted moral reasoning. They may assume that a loving mother can't be dangerous to her children. But guess what, guys? Tragically, love and psychosis can coexist. And in some cases, the delusion weaponizes the wish to protect. Now, the counterweight. It would be unreasonable to suggest that any clinician could have predicted the specific tragedy that occurred in the Yates home. Violence among mothers with postpartum mental illness is exceedingly rare, and psychiatric risk assessment deals in probabilities, not certainties. A patient might improve in the structured environment of a hospital, but deteriorate after they're just discharged. Insurance restrictions and legal standards can limit the length of an admission. Families might misunderstand or struggle to follow recommendations, and symptoms can escalate between appointments. And a patient who appears calm during a brief clinical encounter may be profoundly unwell by the next day. So examining these limitations is not an attempt to manufacture a villain or assign one person the responsibility for everything that followed. The more meaningful question is whether the healthcare system responded appropriately to the information available at the time. In Andrea's case, that information was not limited to vague anxiety or ordinary postpartum exhaustion. I mean, her history included severe psychiatric deterioration after childbirth, multiple suicide attempts, repeated hospitalizations, psychotic symptoms, a significant loss of daily functioning, and consequential medication changes, all while she was living in a home with 5 young children who depended on her and on the adults around her to recognize when her illness had become unsafe. So the tragedy was not that they knew she was sick, it was that they didn't know how sick she really was. And that's a wrap for now until part 2.
Very nice job. I want to again say this is not talked about enough, so I'm so glad you're covering this. As someone who obviously recently had a baby, I did have multiple friends reach out to me to check in. They themselves had experienced some of these things and had shared with me, like obviously they were years beyond this at this point, but were like, I wish someone would have checked in on me. Like, if you are feeling this way, it's normal. Like, I'm here for you. And it was just like, luckily I didn't have any of that. I'm not saying it is right or wrong or, whatever. I'm thankful that people checked in to make sure. But yeah, and they, each of them individually had said, that A, it's not talked about enough, but B, then they felt ashamed and didn't say anything. So that they struggled for so long not feeling like they would have support or feeling like, well, my baby's going to be taken away if I'm truthful about how I'm feeling. And so kind of that fear part of it too. So
yeah. for sure. I mean, new moms, you hear it from everyone has got something to say about what you should and shouldn't do.
Oh,
And it is a world filled with so much judgment when it should be a world like you describe of support and acceptance. I mean, I was terrified to say if I used a certain type of butt wipe, in case it was the wrong thing and someone judged me. So God forbid I say, you know what, I thought about just letting go in the bathtub, which I didn't.
Yeah.
But if I did, I would never have told anyone. So I love that the more awareness we have, the more we can normalize talking about this and supporting each other.
Like mental health matters, guys.
Yep. In our next episode, I'm going to talk about why we don't know more about this and research and how that all failed us as a gender. So we'll get more into it. But yeah.
Well, looking forward to what's to come. Yeah, I mean, you would read parts of this and I'm like, yep, that friend said exactly that to me. And it wasn't even like for all of them, it was the intrusive thoughts of like the tripping in the stairs or like the laundry chute so they just avoided all those things together. It's like, like people I know and love that are so close to me, like that they went through this. So if you're listening to this and you went through it, it's not wrong that you went through it, right? Our bodies are going through immense changes. Our brains are literally changing. And if you know someone that's pregnant, expecting, or just gave birth, maybe just offer some support and know that like these aren't shameful things. It's just part of the process and we're all here for you. It takes a village when you have babies.
It does.
Honestly, a village.
It takes a supportive village. Yeah. We need that village to support mothers, new moms. Yeah. Oh, woo! Listen, before you talk about sponsor number 2, do you like how
you like how you signed me up for it?
Yeah. My mother is intent on reminding everyone that if you have bear country, if you're in bear country, please don't light these outside. She keeps telling me.
That's so funny. Thank you, Mom and Jillian. Okay, you guys, if you live in bear country, maybe think twice about being outdoors with these. However, you can still enjoy inside. And for everyone else, everyone as a group, as a whole, go to tumbleweedandoak.com. Do it. They are seriously so cute. I started looking them up while Jenna was reading last time, which was really rude. But these candles bring a warm, natural glow into your home. They are made with pure beeswax. The company is Tumbleweed and Oak, you guys. They are handcrafted in West Texas. And again, 100% pure beeswax, never blended with paraffin, soys, synthetic fragrances, or unnecessary additives. The result is a clean burning, long-lasting candle with a subtle, naturally sweet honey aroma and a beautifully golden flame. Tumbleweed and Oak is rooted in simple, honest craftsmanship and a love for natural living. Each candle is thoughtfully made to create a cozy atmosphere without overpowering your space or compromising air quality, which we talked about before because I know more about HVAC than the typical woman. Thank you, honey. Perfect for everyday rituals, quiet evenings, gifting, or setting a peaceful mood. These beeswax candles offer a timeless beauty with purpose. Choose Tumbleweed and Oak for candles that are pure, handcrafted, and naturally inviting. Use our code STAYSUSPICIOUS at checkout for 15% off your order. That's www.tumbleweedandoak.com. 15%. Our code STAYSUSPICIous. And I love a candle. And my acupuncturist was like, don't burn the candles I've been burning, right? Because all the toxins. So God, I miss her so much.
Where'd she go?
If you still listen to this, Peggy, I just haven't been there. But Peggy, if you're still with us as a listener, I miss you, Peggy. God, I miss you. Well, I should just probably go there again. I loved acupuncture. Okay. Is it time for a medical mishap and not my acupuncture history?
Yeah, this is a lighthearted one. I hope you enjoy.
Oh, good. I am looking forward. I gotta yawn quick. Okay.
We might as well add that to the soundtrack of the end of the episode.
I know. You should have a button of my yawns. Guys, it's 7:33 p.m. because my baby has been waking up in the night.
Oh, no need to make
so
we get it. We get it.
I don't know if it just growth spurts, teeths, not sure. Doesn't matter. The email reads, Hi, Jenna and Amanda. First of all, let me tell you how much I love your show. Your coverage helps my anxiety by confirming my deepest, darkest fears and illuminating ways to stay safe by staying suspicious. Thank you, writer. I'm making my own quick insert that I'm going to start being better at not making my own inserts. That's why it took me 500 years to read the first couple sentences, because I wanted to insert so many times. I'm not going to do that. But hi, we love you too. Okay. A few months ago, I was cleaning the kitchen while listening to your podcast through my wireless earbuds. Wow. Just kidding. I just made an insert. Wireless. Go you. Aren't they all wireless now, baby? It's 2026. Okay. I'm so sorry, writer.
Well, listen, we started, maybe this was 2025. Was that? Yeah. Anyway. Okay.
Maybe, baby. When I finished, I pulled them out and noticed that the little silicone tip was missing from the right one. Dang it. Okay. I searched everywhere. I checked the floor, the sink, the garbage disposal, and even the dog's mouth. The dog was deeply offended by the inspection, but ultimately cleared of all charges. I decided the silicone piece must have fallen off while I was cleaning, so I replaced it with one of the spare tips and went on with my life. About 2 days later, my right ear began to feel plugged. Everything sounded muffled, and whenever I chewed, I heard a faint squeaking noise. No way. Because I'm a rational adult, I immediately concluded that I was developing a rare neurological disorder. My husband suggested earwax. I told him that seemed unlikely because earwax would not explain the squeaking, and he asked whether I thought a neurological disorder would explain it better. Oh my God, I love your husband. I did not appreciate his tone. I love you too. By the 4th day, I was convinced that my hearing was getting worse, so I made an appointment. The clinician looked at my ear first and said it was perfectly clear.
The left ear.
Looked in the right ear and, oh yeah, okay, I was like, interesting, perfectly clear, not what I suspected. Let me start over. The clinician looked in my left ear first and said it was perfectly clear. Then she looked at my right ear and became very quiet. Finally, she asked, "Do you use earbuds?" That was when I remembered the missing silicone tip. Dun, dun, dun. It had been lodged in my ear canal for 4 days. The clinician removed it with a small instrument, probably an alligator forceps. Gosh, I'm so sorry. It came out intact, accompanied by the most humiliating little squeak I have ever heard. She placed it on a piece of gauze and showed it to me as if she just delivered a baby. I said, "Oh, there it is." And she said, "Yes, we found it." My hearing returned immediately. Unfortunately, so did my husband's voice. Oh, no. He was waiting in the hallway and had apparently heard the entire conversation. And on the drive home, he asked whether my rare neurological disorder had been successfully treated. I told him that it had, and that the treatment required him to buy me lunch. I'm obsessed with you guys. I now inspect both earbuds each time I remove them. I also keep the recovered silicone tip in a small plastic bag in my junk drawer. My husband labeled the bag Rachel's brain tumor. Oh my God. Seriously. Whatever. Rachel, again, I'm so sorry I couldn't stop at inserting you. I'm obsessed with you and your husband. I want to hang out with you guys. Are you free on Friday? I'm thinking margaritas.
Yeah, but make sure it's like senior hour at like 5, because Amanda will be yawning into her margie by the nacho dip by the time the sun crests.
Also, nacho dip? What? Queso. Which Queso.
Hello.
Also, Amanda used to stay up really late. Those days are gone. I'm retired. I'm a happy hour girl. Jenna knew me before I was retired.
Which is why this is
I
so
am
funny.
very much retired. Yeah. Okay, wow. Okay, we're over an hour, guys. Are we ready to sign off on Rachel? Rachel, thank you so much for sending this in. I'm sorry I interrupted.
Okay, so I do have to interject here, because it was so hard to sit still and listen to this, because as audiologists, We hear about this all the time because hearing aids have tiny little buds, much smaller than headphones. And I will say the record at my last job, the record number, some dear old soul kept putting his hearing aid in his ear and pulling it out, and there was no tip on there, and so he thought he dropped it. You want to do you know the answer? Do you want to guess what is the maximum number of earbuds that were found in a patient's ear canal?
Okay, what size was the dome? Before my
Medium
guess.
opens. God,
medium opens.
no one
okay.
else is gonna know it.
Picturing
It
a
was
closed,
man.
smoky, medium open.
Yeah.
Okay, yeah. How old was the man? Because you know those
Elderly.
ears like keep on
Elderly.
rolling.
Old enough to be.
Was he hairy or no?
Oh my God, just guess.
You're like JFC, just guess. Okay, 7.
Oh, okay. Well, it was 6. But I mean, 6. He dumped 6 earbuds in his ear before he went in to get them taken out. Yeah.
That's how experienced I am.
Okay. Well, thanks for blowing that story for me.
That's so funny. Okay, well, maybe ask someone that's not an audiologist.
No,
I don't know.
You're close.
If I wouldn't have asked the size of the dome, I maybe would have guessed differently.
Listen,
See?
the husband labeled the bag Rachel's brain tumor. Love that. But also, I think we do need to end with a message like, if you leave anything in your ear, don't go exploring it yourself. We have so many people that try and jab in there with tweezers or whatever you find in the bathroom drawer. Please, you're going to take a mildly embarrassing problem and turn it into an expensive and significantly more embarrassing problem. So go have a medical professional remove it, like Rachel. Thank you, Rachel.
Yeah.
But next week.
Thank you. Good job, Rachel. I'm glad you got rid of your brain tumor.
Next week, we're going to cover part 2 and of what little we know about postpartum psychosis. And we're going to discuss Dina Schlosser's case. And then I wrote possibly Otto Sanchez and Lindsay Clancy if there's time. Guys, there's not going to be time. So we're going to cover part 2.
No, I have another insert. I'm just going to say it now because what if I don't remember last week? You guys, if you're listening and you are a part of a February's babies 2027, whatever, there's all these groups online you can join and you're with all these tens of thousands of moms who all have babies at the same time right now. And they're all like, is your baby rolling yet? Whatever. When people post on there, that I have seen so many armchair diagnoses of, are you sure you don't have PPA, PPD, PPP, PPP? I'm like, can we sit and not make armchair diagnoses? Thank you. That's my TED Talk.
So these are moms that have given birth and people are questioning whether they have depression or psychosis?
Yeah, it will be like a mom posts something like, not looking for medical advice because, everyone's a freaking keyboard warrior out here. And they're like, how dare you? You should ask a doctor. And they're like, well, I've already messaged a doctor, just messaging this village to see if anyone's went through this or, whatever concern about their baby. And then people will be like, you sound really worried. It sounds like maybe you should be evaluated for PPA or PPD. And it's just just all calm down unless that's actually your realm of work.
And also, let's be supportive because part of what we're talking about is not judging and accepting and normalizing that people go through things. And so also, I didn't mention this, but on our site, I'm going to put a bunch of resources for these disorders that we're talking about. So good stuff. Yeah.
Beautiful. Okay, you guys. I'm getting squirrely. Let's sign off. Don't miss the beat. Subscribe or follow Doctor in the Truth wherever you enjoy podcasts for stories that shock, intrigue, and educate. Trust, after all, is a delicate thing. You can text us directly on our website at doctoringethetruth@buzzsprout.com. Email us your own story ideas and comments at doctoringethetruth@gmail. And be sure to follow us on Instagram at Doctor in the Truth Podcast and Facebook at Doctor in the Truth. And we're on TikTok at Doctor in the Truth and EdAudPod. EDAUDPOD. Don't forget to download, rate, and review so we can be sure to bring you more content next week. Until then, stay safe, stay suspicious. So sorry, I thought of one more insert, but we have over 10,000 downloads, guys. Woo! Okay, bye.